for coming today on a Saturday morning. I'm sure that's difficult for you to do, but I appreciate you being here today. So today what I thought I would do would be to talk about some of the newer drugs and the data that's coming out for patients with different types of lymphoma. And probably turn it down just a little bit because it kind of has some feedback. So some different new drugs for lymphoma, kind of some of the data out there. And then I'm going to talk about a couple of initiatives from ASCO that relate not specifically to lymphoma, but talk about some big data initiatives and also some initiative to try to get molecular data for patients and try to direct some of our currently available drugs to patients who may benefit from them. Oh, just before I go, this is my email on here, and if anybody would like to email me for any reason, you can ask Jazz. I answer email all the time and happy to help you with anything I can. So this slide just shows the potential novel targets for patients with non-Hodgkin's lymphoma and CLL. And you can see that a lot of our new drugs are trying to address some of these targets. And some of the interesting ones that we have new drugs for, that we're working on new drugs for example, the Bruton's tyrosine kinase inhibitors. Ibrutinib is the one currently that's available, of course. There's several other new ones as well that are available there that are being looked at in clinical trials. Several new monoclonal antibodies that are either bispecific or targeted or that are conjugated antibodies also are in clinical trials, and of course there's some that are available as well. Radioimmunotherapy is not caught on as much as we might have liked, unfortunately, perhaps due to technical issues, but actually is pretty helpful for certain patient populations. Novel chemotherapies, looking at different mechanisms, HDAC inhibitors of apoptosis, and the PI3 kinase mTOR pathway is also one that there's a lot of excitement about. Next slide. So for lymphoma, we've been keeping the FDA pretty busy over the last few years, and this is just since end of 2013, the things that have been approved for non-Hodgkin's lymphoma and CLL. And you can see there's new antibodies, there's the BTK inhibitors, PI3 kinase inhibitors, HDAC inhibitors, and so things have really moved pretty quickly over the last couple of years compared to previously getting new drugs approved. The FDA has been a bit more flexible. They have the breakthrough designation now and different ways to get drugs available for patients sooner. So it's been quite helpful. Next slide. So these are some of the areas I'm going to talk about briefly today. Talk about some of the new data that's available. Immune checkpoint inhibitors, PD-1 and PD-L1 there's a lot of excitement in various different types of cancers related to this. There's a little bit less information about lymphomas, but I'll show you what's available. And I think you'll find in clinical trials that a lot of the checkpoint inhibitors are really out there and being tested in either alone or in combination for many of these different lymphomas. CAR T cells are something that's not a lot of data available, but for the few studies that have been published in lymphoma or ALL, there's some real excitement in that. I'll show you what's available, currently available for information. A little bit of information about some of the new antibody conjugates that are in clinical trials, and then pathway agents are probably the area that are most exciting with respect to medications for new patients, either alone or in combination. Next slide. So just to talk about the checkpoint inhibitors, or immune checkpoint inhibitors, PD-1 and PD-L1 are the areas that are targeted for most of these, although as I'll show you in a minute, there's different potential targets in the same immune pathways. And they're trying to see if we can obviously activate the T cell against a cancer cell, in this case lymphoma, but there's also lots of information, as you know, and some are already approved for other solid tumor cancers. Next slide. So specifically for lymphoma, this is the data that's available, and most of this was presented at ASH this past year, American Society of Hematology. So for nivolumab, there were two presentations at ASH, and also pembrolizumab, there was a big presentation at ASH. And both of these agents really were shown to have very high activity, specifically for recurrent Hodgkin lymphoma. And the nivolumab had 87%, or 20 out of 23 patients responded. These were patients that had failed transplant, failed brentuximab vedotin, failed everything basically. and had a very high response rate. And there are some of these patients that have stayed in remission now for a couple of years, actually, from these original trials. So it's looking quite exciting, specifically for Hodgkin lymphoma, for both nivolumab and pembrolizumab. Small numbers of patients, but I think we'll be seeing over this next year updates in some of these original trials and the new trials that continue to show very high response rate for patients with Hodgkin's lymphoma. Now, the nivolumab trial also had a number of different types of lymphoma patients in there. You can see the response rates there were not as good as Hodgkin's, but impressive in a small number of patients. So follicular, diffuse large B-cell, both were about 40% of patients that responded. So there's a lot of new trials trying to look at different types of lymphomas, Hodgkin's as well as non-Hodgkin's, to see if this will continue in a larger patient population. There's also some trials that are combining some of these agents together with pathway agents, such as the BTK inhibitors, because based upon the interaction there, that should actually augment the addition by adding those two together. So we have one trial that is looking at a BTK inhibitor plus pembrolizumab, and there's multiple other trials that are out there looking at combinations. The other two, ipilimumab, has not been tested very much for lymphoma. It has a small response rate, but not very many patients have been treated. And then pembrolizumab is another PD-L1 antibody that's in testing. It has not, again, been tested in very many patients, but also had some response rates in that. So I think they'll be seeing a lot more information over the next couple of years in all of these areas. Next slide. Now I want to switch to just talking about the CAR T cells. And CAR T cells have been something very promising, but not very many patients have been treated. It's a very time-intensive, labor-intensive type of treatment, similar to a transplant, basically, for these patients. So this methodology, the peripheral blood mononuclear cells are collected by apheresis. They are taken then ex vivo and externally T-cell activated by a number of different techniques, by transduction. And each type of trial basically has their own technique as far as how they transduce that. And we're trying to have T-cell proliferation that are specifically, in this case for the most part, anti-CD19. So the CAR T cells then are given back to the patient after the patient receives a lymphocyte depleting therapy, and typically that's something like fludarabine, Cytoxan, or other similar types of regimens. So a kind of a reduced intensity regimen for transplant, basically. And then the patient receives the anti-CAR T cells that have been given back to them. It takes about 2 weeks to manufacture these cells. So there are a number of different centers or sites that have been working on this, and this slide goes over a number of those. And many of those now have been taken to commercial testing, although there are not very many centers open yet on the commercial testing side. So these are most of the trials that have been published by the individual centers so far. So UPenn, and you can see they have the co-stimulatory domain that's different, and the transduction method is different in all of these different areas, and the biovector is different. And you can see the indications for treatment. So UPenn then licensed that to Novartis. MSK, Ramoso Kettering, and Fred Hutch, together, they had the same technique. They licensed that to a company called Juno. And NCI had several trials, actually, and they licensed that to a company called Kite. And those are the ones that are farthest along. There's also 3 other companies that are looking at different types of CAR T cells as well that aren't quite as far along. So you can see that most of the patients were ALL and non-Hodgkin's lymphoma. There's a few CLL patients treated with this, but not very many so far. So this slide shows some of the results from some of the phase 1 and phase 2 studies. And you can see here the phase of the study, the disease, which of the different agents was used. This can really only be used in really fit patients because you have a pretty high toxicity rate, and that relates to cytokine release syndromes and also some neurotoxicity. So these patients are screened very heavily for making sure that they have good cardiac function, good neurologic function, high performance status, those sorts of things. So you can see most of the patients were under age 60 typically. Prior treatments, many of these people were very heavily pretreated, had transplants in the past, and multiple other therapies. Patients typically, as I said, get a lymphodepleting chemo, although it's different in the different trials. And you can see the response rates there. So there were some patients that had complete responses and a number of patients that had partial responses. Some of these studies have gone now for several years with patients remaining in remission. The NCI trial has multiple patients that have been in remission for quite a long time. And then the toxicity, it does cause hypotension, cytokine release type symptoms. And one patient had a fatal neurotoxicity in one of the trials. So you have to be, basically this type of treatment has to be given at a very high level transplant center, because you have to know not so much how to manufacture the cells, because they're coming from a pharmaceutical company now, but they have to be given at a center that knows how to take care of these types of side effects. And so I would say that, at least for right now, it should only be given at a very high level transplant center. Duration of response, there's some patients, as I mentioned in the KITE, or the NCI study, which is the one that's now called KITE study, the first column, that have been in remission now past 2 years. And so those are patients with relapsed diffuse large B-cell lymphoma. There have also been several patients with relapsed ALL that you may have read about that have been in remission actually for quite a long time too. That was the one at UPenn. So some really promising techniques here. I think we don't really know where this is going to fit in. Potentially it's going to be very costly, so obviously we only want to do it where it's very appropriate for patients, but exciting, I think. Next slide. So the challenges for the CAR T cells are that you have to be able to try to control them, which we don't exactly know how to do at this point because of some of this toxicity issue. Some of the toxicities can be aggravated by an anti-IL-6 antibody, and that's been used in several circumstances. Probably the neurotoxicity is the one that's least understood. The cytokine release syndrome, the IL-6 and steroids tend to aggravate that. But the neurotoxicity, nobody really understands the mechanism of that, so that's something that's being looked at. Long-term B-cell depletion is unknown. Most of these patients really aren't long-term, so we don't know that. And then we want to make sure that we target specific subsets of T cells. Again, that gets to the area that you want to use for the different types of T cells, maybe for different patients. We don't know about that yet. And how to improve the availability. So it'd be nice to be able to have a non-viral vector that you can use for this type of treatment. And we'd like to get the allogeneic transplant effect without having the complications of the allogeneic transplant. So that's kind of the idea behind these. So if we can try to use this without having to have an HLA matched donor, but still get the allogeneic effect, that would be ultimately what we're looking for. We'd like to replace allotransplant because it causes lots of problems, graft versus host disease, immune complications, and all the things you're familiar with for your patients. So if we can get that same effect without all the complications, that's really the end result we're looking for. Not there yet, but certainly I think patients in clinical trials over the next couple of years are going to show us some of these things, and we're going to refine that. Next slide. So, this is just a cartoon of looking at the B cell and looking at some of the targets. And on the left is the CAR T cell, so it's an engineered T cell. There's also ways to potentially improve that by, again, using the PD-1 pathway, because you can kind of hit the B cell from two different areas and try to enhance the effect of the CAR T cells. So I think down the line we're going to be seeing, again, a lot of these combination potentially for specific patient populations. Next slide.